Okay, and we're going to start recording now. And we're also going to be going live on Facebook at LSU Health Foundation. Too many pages.
All right, welcome everyone. We are excited that you are all here. There might be some different things going on with how this webinar is running today. So we're going to do our best to keep people muted to help with interference, and then we'll take questions, so be sure to post your questions. We are joined today, we have a really special webinar. We have Dr. L. Ciccarelli. She is a recent graduate of our LSU Pediatrics residency program. She's now practicing in the United States Air Force. And she started a wonderful program to support our residents during this crisis and trying time. She's running our show today. So welcome, Dr. Ciccarelli. We're grateful to have you here.
Thank you so much.
The show is yours.
Oh, okay. I didn't know if you had the CME slides.
Oh, did it not pop up? I'm sorry.
Just remind you about the conference.
Here is the CME slide. I'm sorry, I'm having so much trouble getting this up today. But this is
Are you there?
eligible. Oh, sorry.
The LSU. The medical education and impact of COVID. Right now.
Okay. All right, y'all. So here is the slide. And that's what we needed to show. And I'm going to stop sharing now. So we will get back to the show.
Okay, thanks. Yeah, thank you guys so much for joining us. Again, I'm El Ciccarelli. But today we're going to explore an aspect of medicine that every single physician in the United States has experienced, and that's the training years of residency. It's the time after medical school, and it's this long journey, basically, when you are a physician, but you're still learning the skills to become clinically excellent in your field. And New Orleans is very lucky to host a large number of medical trainees across many, many institutions, and these trainees bear a very big portion of the workload across Louisiana. So I recently finished my residency training. I'm a very proud alumnus of the LSU Pediatric program at Children's Hospital. And since I miss my coworkers so much, I started this program to support many doctors with lunches from local residents. It's called the NOLA Doc Project. We'll get the information to you if you're interested, but we've served over 2,000 trainees meals over the last 6 weeks across hospital wards, ICUs, and ERs. And they're working to both further their clinical education and to protect us all. And of course, with the LSU Foundation, we've generously been able to set up a fund to continue this focused resident support.
Blue Angels are flying over New Orleans today.
Our focus today is going to be to discuss the impact that COVID is having right now on medical training in terms of the environment and the growth on physicians. And we have physicians from all levels here today to speak about the varied facets of what the medical training environment is. And please feel free to share any personal anecdotes that our listeners can connect with. But going around, I see we have Dr. Matthew Carlisle. He's the emergency medicine program director, so he can provide that kind of birds level input. If we have any, we have Dr. Engels and Dr. San that may join us, and they're the internal medicine residency program directors. All of those three program directors have mentored many, many residents over the years, but a lot right now in the face of direct patient care with COVID. We also have Dr. Malhotra, a palliative care director at University Medical Center, going to provide us some insight in terms of coping skills and mechanisms. And then we have a couple of residents joining us at the ground level, Dr. Lake, Dr. Zamora, and Dr. Dubuque. So thank you guys. So the first question that I want to start off with, maybe a little bit oriented towards the program director level, but the medical training environment is really unique in that while we're trying to meet not only patient care needs, we also need to educate residents. So in the role that you've taken in the crisis, how have you worked to balance those two tasks?
Yeah, I think it's always a challenge, right? I think there was a conversation on a national level of whether these patients need to be seen by the residents. Thankfully, the ACGME kind of stepped in and put a statement out there saying that they absolutely should be, because I think that would have seriously impacted our resident education here at LSU New Orleans. It's been really interesting from the ER perspective. At the beginning of this, there was a huge run. There was a big, obviously, that we were extremely overcrowded for a while. It was a really dangerous sort of time to be part of it with our usual influx of patients, plus these COVID patients that were really difficult to sort of suss out clinically where they were going to go. Kind of like everybody learning a new disease process, and we're trying to teach the residents while learning about these patients too. So I think that was a real big challenge at the beginning. And now what we've seen, it's improved somewhat in the last few weeks probably, but we've just seen a huge drop off of anybody but COVID. And so I think it's interesting. I don't know that anybody expected that to happen, to impact our training there, like, and begging patients to come back to the emergency department. I think was ever in our sort of view of what was going to happen with this global pandemic. It's not a problem that is just LSU New Orleans. This is a nationwide problem of people just stopped going to hospitals because they feel like it's not safe. So I think that was an unexpected challenge. I think we luckily with things like Zoom platforms like that, we've been able to keep in contact with our residents from and able to do like weekly conferences. So we actually, I don't even think we missed one weekly conference because of the technology that's there. That's kind of what we do in emergency medicine. We kind of figure out how are we going to get through this? All right, we'll just spitball and we'll kind of piece it together and MacGyver something. And so I think that I think long term, we hope that the patients will come back so we get to see our bread and butter strokes and our MIs and things like that. But it'll be interesting in the future of what we do.
That is very fascinating. And I think unexpected repercussions and unexpected consequences have sort of been this refrain. We do a thing, we're trying to address something, and then this unexpected consequence kind of comes back around. So that's a super interesting perspective. Do we have we don't have any other program directors with us? Okay, well, thank you so much, Dr. Carlisle. The next question that I wanted to talk about is actually a little bit more focused towards Dr. Malhotra's area of study, and something that really I was in the mindset of when I started the NOLA Doc project is thinking about resident coping and how coping with stress and coping with bad patient outcomes that are going to happen is a huge part of medical education. So do you say, would you say that what's your approach been, sorry, in terms of helping medical residents cope with the stress of COVID during these times?
Yeah, I think that's a great question, Elle. And, I think everybody has their own sort of methods of coping. And I think a one size fits all approach is the wrong way to sort of teach coping and resiliency skills, because everyone's a little bit different. And so what we've tried to do as a palliative care team at University Medical Center, because we service both LSU and Tulane residents, is try to establish some basic methods that we can sort of apply to a more global group. So for instance, rounding with the ICU teams every morning, huddling with the residents first thing in the morning. And I made it very clear to my staff that when this pandemic started, we were not going to do attending to attending conversations. We were going to make sure that we were doing attending to resident conversations, including the residents in sort of any sort of discussions about patient care, and then also checking in on them, using that opportunity to check in on how the residents were doing and what we could do to offset some of their sort of stressors. Talking to families when you are trying to do high level ICU or floor work, is one of the hardest things to balance out in the day. And so we let the residents know that we were there to offset any of their concerns. So whether that meant calling families, whether that meant talking about prognostication, whether it meant phoning them into goals of care conversations, we wanted to do as much as possible to help support our residents through some very devastating cases. And I think that has really boded well, checking in on them on a daily basis. Consistency makes a big difference in terms of resiliency building and self-care. And then also encouraging the residents, asking them what their highs were and what their lows were. In our line of work, we actually on a weekly basis get together as a palliative care group and we ask each other about our peaks and valleys. And I have to give a shout out to my colleague, Dr. Michelle Christopher, who came up with this. And, you know, she really has encouraged us to think about what are our highs and lows of the week and to reflect on them. The other thing is self-care, making sure that even in these crazy times that we are doing things that make sense for us, making sure that that's incorporated into daily life. For me, it's been taking 6-mile walks on Saturdays and Sundays with my husband and my kids. And so we're walking 12 miles every weekend along the lake, and making sure that we're teaching residents that that is important for their well-being, especially when dealing with such devastating cases. And I have to say, as a palliative care doctor, I deal with death and dying a lot. The COVID pandemic has been very unique to me. To see so much death and dying in such a short period of time has really taken us by surprise and has really been surreal, to say the least. And so having those mechanisms is very important. And we as attendings need to do a better job of teaching residents how to build resiliency, how to build those coping skills, how to build self-care into their practice. We also host a death cafe at University Medical Center that is open to anybody that works at University Medical Center. And we had the highest showing this past month for Death Cafe in April, where everybody came together to talk about their experiences with death and dying related to the COVID pandemic.
Wow.
That's so incredibly amazing to hear all of these varied approaches, you know, in terms of integrating it, the resiliency training and with the care while we're doing it, and also kind of taking that time after we do our work to take care of ourselves. And I want to give our 2 resident doctors a chance to comment on their experience with coping and resiliency, Dr. Dubuque and Dr. Zamora.
Just want to make sure I'm unmuted. Can you hear me?
Yes.
Okay. So I'm Jake Dubuque. I'm a second-year internal medicine resident with LSU program in New Orleans. I believe we have Dr. Zamora, my colleague, here as well. You know, we've been through a very interesting couple months. Certainly different than what we expected to have as residents in this training program. Very, very, as Dr. Carlisle was saying, I'll reiterate that our focus was COVID-19 and education and learning opportunities on other realms of medicine and different diagnoses was kind of out the window. This whole hospital was filled with COVID-19 patients who needed our care and attention. So shifting gears toward COVID-19 was difficult for all of us. Changing didactic sessions around to make sure that we could focus on this solely was certainly distressing. Dr. Walter talked about coping mechanisms and, you know, ways to decompress after stressful times. And I have to say, with her guidance, with the guidance from the rest of the program directors and administration of the hospital, we were able to really pull through and step up in these times to really focus on the just horrible disease that COVID is. I'll put all things else aside. Certainly, there's a lot of logistic difficulties and fallout that will come from this, but the ACGME, the licensed boards, everybody's been, willing to work with us in their open arms regarding policy changes, duty hour restrictions. When it comes to logistics, we'll all deal with that at a later date, but really our focus was COVID-19, and that's really it. It was very, very different in that regard because that's all we were learning about, all we were focusing on. But I think it was for the best. I don't know if Dr. Zamora wants to comment more on the radical change we had as residents. You might be able to a little bit more.
Yeah, no, I agree. You know, we had to, shift our focus, like Dr. Dubuque was saying, and really just adapt to what was going on. You know, I think one of the biggest things was keeping up with all the new information that was coming out, and trying to do what was best for our patients, and hoping for the best. So there was a lot of that. So we definitely changed a lot of things as a team, and I think that was one of the biggest things was working together as a team and figuring out what worked best for the patients. And I think I enjoyed working with the team we had. We were able to come up with what we thought was most efficient or the best way to take care of our patients. And another thing too was making sure we were conserving PPE. That was another thing that was an issue. So we had to work as a team to get that in line as well. But the biggest thing was adapting to everything that was going on. And that was I think as residents, I think that was actually good learning opportunity for us as well. It was a good training thing, because it's something that could happen again later on in our careers, and it's not something we expected to have to adapt so much, I think, in something like this. So yeah.
Absolutely. I think you hit a lot of high points, especially, that medicine is a team sport. And then also that whenever you're learning a lesson in residency, it has this sense that you're learning it forever. And I really, want to learn this lesson right so that I can carry it forward and be the kind of doctor that, I want to be and that I've always tried to be. So another one for the residents, what's a particular trait that you've seen embodied by a lot of the attendings that you've worked with, maybe that you might hope to carry through to your practice in the future?
So I could probably answer that one. And I'd have to say, it's simply compassion. As I was stating before, we kind of had to put a lot of our training and education to the wayside over the last 2 months. And at first I said, we'll forego the education, we'll focus on the patients for right now. But it was pretty quickly that I realized there's still a lot of educational opportunities for us in this crisis. And I'd have to say, hands down, the biggest thing that we can learn from this is how to be compassionate doctors, how to talk with patients in very, very difficult situations, not being able to communicate with family very readily, as most hospitals had visitor restrictions. And of course, the death and dying aspect, because unfortunately, so many of our patients finally passed from this illness. Hands down, Dr. Malhotra, especially from the palliative background, she's always, been so good with that compassionate side and dealing with the critically ill ICU patients whose families just hopelessly waited to hear news. It was certainly an educational opportunity for all of us on how we can incorporate compassion into our practice.
Absolutely. I think we can still feel compassion even virtually once we, figure out how to log in and get the programs working. I kind of want to bring this back around to Dr. Carlisle. In terms of running a residency program in the midst of a crisis or a pandemic, what ways do you foresee yourself or your program or your institution preparing differently for a pandemic or a disaster in the future?
I think it's, it would have been nice to have a little bit more foresight. I think being able to see this coming, or maybe we should have been thinking about this in January, a little bit more of like when this happens, what we'll do next. I think we're still trying to learn the lessons from this one. I think we're still from a residency program figuring out how to deal with next year. Like what's going to happen? How do we grow the program? How do we do medical student rotations? We still don't know if we're going to be able to do away rotations, like have visiting students. So how is that going? I just had a conversation with my APDs, like how is this going to be? How are we going to do interviews next year? How do we recruit people when we may not even be able to get them to come here? I think big part of who we are and who we sell is one is New Orleans. As it's a fun place to visit. It's great to go and you get to see who we are. And we rely heavily on our interview season for recruiting it residents. I think we have a good strong name, but it's really our residents who sell our program. And so if they can't come, they can't meet these people. What do we do? So in terms of lessons learned, I think it's it's still sussing it out. I think making sure that we maintain didactics, I think is very important. I think what's at least to know what's been beneficial. I think what you started, like the things that have been the programs that are going on, the NOLA Docs group, the Feed the Front Lines with Devin DeWolf and that the crew of Red Beans, knowing that our community has our support has been great. And I think that has done so much to boost the morale of the residents. And I think that's been a lesson learned of one of the things that we focused on, at least from emergency medicine, and I'm sure that all the other programs will do the same, is that resident wellness was such a huge part of what are we going to do? We knew this was going to be a marathon. We knew this wasn't going to be a sprint. So part of the things that we did is we pulled back from other sites. We actually we pulled back from some electives, some other things. We've really put more people in the ER than we usually do to try to decrease the shift load, decrease the risk to the residents, decrease those sort of things, and kind of bring everybody home. So we had a sense of community, of togetherness, of that here. We've been very vigilant about sort of stacking residents, making sure that the backup has backup. So that way when people either get sick or people they get too much overwhelmed from a stressed out standpoint, that sort of thing, that they need to take a step back, they didn't feel guilt in doing that. I think that that's always been a problem with residency. It's always been an emergency medicine, the number of residents that used to come in with either flu-like symptoms or fevers or something like that was just not a thing. And I think that instead of the burden being placed on the other residents, and that idea of like, well, when you don't come in and you don't show up, somebody else has to take your place. I think we really tried to lower that bar of saying, look, no, you can't do this. And so hopefully we'll carry that forward next time the pandemic like this rolls through, that we have that sense of understanding of what constitutes wellness, what we can do to improve.
Awesome. Echoing kind of the idea that medicine is a team sport, and echoing this kind of buddy mentality that we often actually see in my practice in the military, supporting each other. But to kind of bring back around to our theme, which was growth through adversity, a lot of times I really think that troubled times can bring out the best in people and can make things that we never thought possible. Case in point, the military has decided after 20 years to do telehealth. So that's a really big change that's going to impact my personal practice. Could any of you guys comment on anything that you foresee your personal practice of medicine changing in the future?
I mean, I can certainly speak to the fact that palliative medicine has always been a very personalized discipline of medicine. We've been the huggers, the handshakers, when we meet families and when we meet patients. And I think our field has changed so dramatically now that that's not a possibility. I think we do have to embrace technology to allow people to see their loved ones. I think this pandemic has shown us that people want to see their loved ones. And so we've used, sort of video platforms to show families their loved ones when they're in the hospital. We have used technology platforms to do psychological first aid groups through the LSU trauma group, this psychology trauma group. Tulane is also using a video platform to do psychological first aid groups. You know, I think we have to embrace that, and knowing that each one of us has been changed by this experience, and really to reflect back on that. I actually picked up my habit of journaling once again, which I haven't done in over 10 to 12 years, to ensure that, you know, I am attending to my own emotions. And I think one of the things we forget is that we are human beings. If we don't attend to emotion, and this is one of the things I teach, you know, with patient-family interactions. If we don't attend to patient and family's emotions, that emotion is certainly going to come out in some form or the other towards the physician or towards the healthcare group. It is the same for us who provide healthcare for people. If we don't attend to our own emotions, at some point they will come out. And so, you know, being able to use different platforms that make sense for us to be able to attend to those emotions for ourselves and for our patients and families, so that we make overall care better for everyone who's involved in healthcare.
I agree. I think that telehealth has been a big part of what we've been doing. We used telehealth initially, just being able to put a camera in the rooms in the ED and be able to interact with the patient, so you can minimize our PPE, minimize our exposures. But I think this is the first time we actually have some of our faculty have been doing telehealth visits. So I couldn't have ever foreseen in residency or in medical school doing emergency medicine via telehealth. But that's kind of part of our new reality. So I think that that's probably going to grow even more. I think that we'll see probably some of that telehealth triaging come out from our daily practice.
Yeah, from an internal medicine standpoint, for the last 2 months, we've been seeing all of our primary care patients with virtual visits, either on the telephone or with Zoom meetings. And in my opinion, it's been working great. And I think we've proven the fact that the medical community is ready to embrace more of this telehealth platform, and so are the patients. It's really been a wonderful tool that we've been able to use and not expose people to this virus. So I think you know, I'm for it. I'm ready to see it integrated into more medicine in the future.
Absolutely. And I just have a few more questions for you guys, but if everyone else that's watching our webinar wants to go ahead and post questions to the chat, we're definitely going to have some time to choose from those. But I have another one for the residents. So my sister-in-law is actually a second-year internal medicine resident at Tulane. She's a fantastic physician, and she has been interested in infectious disease for years and years and years and years. And she was joking with me the other day, well, now everybody and their brother is going to want to do my specialty. And I just thought it was a really interesting kind of comment. But it leads me to the question for the residents. Has this experience made you feel any differently about maybe any future career choices in terms of where you want to practice, what specialty you might want to practice in, you know, academic versus non-academic, all of those factors?
Hey, I wasn't sure if I was unmuted. So yeah, no, definitely. I think you know, before all this happened, I was interested in pulmonology and critical care. And actually, you know, during all this crisis, I didn't work in the ICU, but I worked closely with some of the patients that ended up going up to the ICU. And so getting that experience and seeing how everyone, especially the ICU, was working hard and to find out what was the best thing to do for these patients, kind of further ingrained that. I think the other thing too is, you know, I think, you know, our program has or any residency program really is, you know, teamwork is very important. And it ingrained wanting to stick with the academic side of medicine as well with this, because I think, you know, working together as a team and learning this together was a big thing for me. So I definitely, you know, think it didn't change anything for me as far as my future career goals. If anything, it just ingrained it more heavily. So that's what I would say to that.
Yeah, I'm with Dr. Zamora on that one. It's certainly very, very interesting. I mean, I've never really got this deep into, very minute, viral transmission data and genomics and vaccines and experimental trials for medications to treat things like this. It's out there, and it's very fascinating and intriguing. But has it changed my mind? Do I want to be an ID doc? Not so much. But certainly, the lessons I've learned through all this is definitely going to be carried with me into any practice I go into. Yeah, that's how I feel about that.
Awesome. And then my final question is a little bit more lighthearted, but it's something that my husband actually helped me kind of figure out and think about when I was first beginning to teach. And I probably taught from day one because I realized as an intern that if I taught my medical students how to do things, then I wouldn't have to do them. So maybe a little bit self-serving, but I've always really enjoyed teaching because, being accountable to a learner's understanding, I think just makes everybody better. But I have the tendency to be a little bit harsh at times. My military training can come out. And I remember coming home one day really frustrated as a senior resident that I wasn't getting good communication and feeling like I wasn't really able to develop an intern very well. And my husband said, well, let's watch Scrubs because you need to decide if you're going to be a Dr. Cox or a Dr. Kelso. And if anyone has ever seen Scrubs, it's funny, the dichotomy between these two physicians, because Dr. Kelso is this kind of older guy that is very into ceremony and doing what appears to be the right thing, but can be very, very mean. And then Dr. Cox appears to be very, very mean, but he's really this kind of fluffy teddy bear guy inside that really, really cares a lot. And I decided that I really wanted to be a Dr. Cox where, yes, I can be intense, but it's really about making sure that the learner develops into a physician that's going to take care of patients in the best way possible. So to all of the other physicians, are you a Dr. Cox or a Dr. Kelso, or choose your favorite TV doctor that you've ever seen? And some older examples might be Hawkeye from MASH, Dr. Ross from ER, and of course Bones from Star Trek. I'm very proud of this question.
Nobody's jumping on this grenade, are they? It's, everybody's kind of standing back. I mean, I would like to, I think I would go with JD from Scrubs if I could be any of them. I like, he kind of the not knowing part of it, right? He's still learning, he's still getting there. He's still both Kelso and Cox, depending on what he feels like is the right thing. And so I think that's to me who I would idolize with those. Maybe a little bit silly, but also can be serious too. So, but I think that there's something to learn from all of them. You need to take the individual, you need to like have that compassion, have that understanding, but you also have to be able to see the 10,000 foot view of the hospital like Kelso has, this understanding the politics and understanding what this impacts of the system. And so I would say both, all, maybe.
I'll accept that.
I'm going to name the fact that I didn't know any of these doctors, and I had to ask, who these doctors were. That shows you how much TV I've been watching. I think one of the things to recognize is that we all have different roles at different points in our career. I can't quite answer your question without saying maybe a combination of all of them, the lifelong learner, as well as the person, who has to interface with administrators quite often. And being able to be transparent to my faculty when I have to interface with administrators to tell them the reasons why I'm doing things is part of my learning process, is being more transparent with that, because there is a certain hierarchy we all have to work within. And I think sometimes we forget that, especially during a training phase where you're only interfacing with your program director, and then your program director has 3 or 4 levels to report to thereafter. And then, you know, your medical directors have 3 or 4 levels even more to report to. So, you know, just remembering that everybody works within a hierarchy, and when you have questions, ask them. And for us as leaders and program directors to be able to explain those as transparently as possible. I would like to think of myself as someone who is a lifelong learner, who is always trying to improve my skill, whether it be communication or empathy. And as a medical educator, that really is the goal. You know, each individual learner needs a different style, and we need to attend to that.
Thanks.
Was Dr. McDreamy from Grey's Anatomy an option? No, I'm kidding.
For you, for sure.
Later. I'm gonna get flack for that later. No, you know, when you said Bones from Star Trek, that's Dr. Leonard McCoy, and that kind of resonated with me. He's all business, not a lot of play. And I feel like over the last couple of months, I've really been able to put my head down and really focus on, you know, being a physician. And not have to worry about, you know, any outside pressures. I mean, obviously there's not a lot we can do outside of the hospital. But, you know, I kind of consider myself, at least for the last few months, being a Dr. Leonard McCoy and really getting on the front lines and fighting those battles with Captain Kirk and them. But yeah, that's who I compare myself to.
Awesome. Well, I super appreciate you guys playing along with that little bit of introspection. So I'm seeing in the chat a question from Sam, who is our tech guru, just wanting me to talk a little more about the NOLA Doc project, and I'm happy to do that. So as I said, I am a graduated resident of LSU, and I'm in what feels like a state very, very far away. I'm physically located in Texas now. And when this whole thing started, I just couldn't get my mind off of what my coworkers in Louisiana were going through, and seeing the counts get so high for New Orleans and Louisiana every single day. I think I really see training in New Orleans as kind of a badge of honor, and the idea that you have seen really the worst of the worst in terms of sick people with very little support, and just remembering that environment. So I started off by sending pizza to my resident program at Chinola, and having a sister-in-law in the medicine program, she connected me with the 3 large inpatient hospitals. We connected with some ER docs. And within a week, we were sending out 200 to 300 meals a week, specifically directed at resident teams. And we tried to get healthy because there was a lot of pizza fatigue in the early weeks. So there was definitely a vegetable included because they came from a pediatrician. There has to be a vegetable. And we got them to take pictures, and it was this fun thing that they would take a break in the middle of their day and recognize that there was this community of physicians and other people that really did care, and really wanted them to take a minute for themselves to be silly and take a picture and eat lunch together. So from that grew a GoFundMe and Instagram account, and we hit 2,000 meals last week. So I'm very excited and very blessed to have been involved in this way, and I will always feel connected with New Orleans, especially with the residency training that I got there.
Great.
Well, thank you so much, Dr. Ciccarelli. That program that you started obviously met a tremendous need for the residents, especially at LSU, and it prompted a bigger discussion about how we meet the residents' needs as a whole for LSU Health in New Orleans. And we've started a new fund called the Resident Wellness Fund, and it's being managed by the institutional officer at LSU Health that oversees all residency wellness and programs. And those that wish to make donations can make donations to that fund. You just earmark it. You can go on the website and do that. And we're additionally entertaining folks that are looking at PPE and donating PPE to the residents of LSU. While we know that that is a concern, that there is a shortage of that equipment to keep our residents safe. So we appreciate your go-gettedness, I suppose, or, you know, just taking the initiative and doing that and bringing that to the forefront, so that we could also know that that's a need, and then be able to give that to our donors and our LSU family who, you know, want to be able to step up and do their part as alum and as a community. So thank you.
Of course. And I'm actually seeing, we have a question that's from one of Dr. Carlisle's fellow program directors, Dr. Engel. So could we unmute him so that he can talk with us and maybe provide some of those insights?
Sure, give me 1 second.
Dr. Engel, thank you so much for joining us, and I see your question. Did you want to say it out loud and we can kind of start a dialogue?
Can you hear me? I'm on the phone. Can you hear me?
Yes.
Yeah. All right. Sorry. Yeah, I'm on a computer in the hospital. Somehow our computers in the hospital don't have video and don't have microphones. Good place. So I got Dr. Sani's phone. Yeah, I asked a question about the AMC recommendations to keep medical students out of clinical duties related to COVID. And this actually also stems from times when we've had hurricanes and there are concerns about allowing residents to stay on for hurricanes. And my concern is, how do we train trainees to handle medical crisis if they're not involved in it?
I can start off, and I'm obviously not higher up in medical education, but I did recently read about this because from a military perspective, the military had actually decided to limit resident involvement. And from the gist that I get when you do kind of the ethical analysis, it's that a medical student may not necessarily contribute to that patient's care, and they may get more, risk from the situation. So ethically, that's why we've decided to necessarily keep medical students out of those rooms. But I agree that it is a balancing act because we don't want anyone to miss out from these really, really important lessons. So I think what we've done in our program, and I'm sure it's similar across the board, is involve them however we can and allow them to take that risk if they choose. So we have a couple of pediatric residents that are going to be ICU crit care fellows, allowing them to take that risk and treat COVID patients and get that experience that's a little bit more relevant for them, has been something that we've done, kind of weighing the risks and benefits on an individual level. But I'm sure Dr. Carlisle and Dr. Malhotra have more high-level views on this.
I mean, I can't say that I have high-level views on it. I think that, when we weigh out sort of ethical decision-making, we have to balance the 4 ethical principles, right, of autonomy, beneficence, non-maleficence, and justice. And certainly, one approach is to sort of allow medical students to make that choice. I think my worry about that is, how do you sort of know whether the medical student has enough insight to understand the risks and benefits of what they're getting involved in? That's one of the things we weigh out when we're talking about capacity in a clinical setting. Does the patient or the family understand the risks and benefits involved? So I think those are questions each institution has to answer. I do think we owe it to our medical students to protect them. And are there unique sort of innovative learning ways that we can develop so that they still receive this education, whether it be through a technological platform or be it through, having structured didactics through these sort of telehealth platforms. We have integrated some of our medical students into communication skills training. So we have actually done some communication skills trainings with our medical students and our residents who are not allowed in the hospital. And then we have actually supervised them on the phone. And then once they have demonstrated a certain level of competency with that, allow them to call on their own. And then when we need to talk about higher level skills like prognostication, then we get back on the phone with them and we ask them what their learning point is from each encounter that we do with them.
I don't think I can have a better answer than Dr. Malhotra there, but I think part of the limit we were doing at first, at least at UMC, I know, was to limit the PPE burn. So it was part of that just conservation of resources of having a medical student. And then you knew the resident would have to come in afterwards, and then maybe the attending also. Then you're using a lot of PPE on that patient. So I'm sure that's part of it. But I'm with you. I think it's obviously a balancing act, Dr. Engel. And we, like I said earlier, we use our rotations as recruitment tools. And so to not have that and missing out on a whole generation of or a whole few months of people is going to be really interesting next year when we talk about our new residency class.
Yeah, this is Lee Engel again. Yeah, I threw this question out because it is kind of controversial, you know, with the students. Then you up it to the residents side of point of view, and it's like, are you going to force residents to see patients with COVID? And different places have taken different stances on that. In our program, we took all our residents and put them in the front line. But I know a lot of faculty, such as myself and many others, basically we saw the patients and tried to let residents keep, protect them as much as we could. And as things moved on, certain residents certainly said, well, I want to be more involved, and that became more the case. So, it is definitely controversial, but it is a balancing act, I think, to be able to train people to handle crises like this. Because unfortunately, these will happen again. Could be a infectious thing, could be a major trauma, could be a natural disaster, storms, whatever. So things to look forward to, I guess.
I'll just say that I give all the credit to my residents. I mean, that's part of our ER mentality is are throwing ourselves in, and we'll suss out the rest of it on the back end. But taking care of patients first is what we do. But I think our residents really embraced it wholeheartedly. And I don't think that there was ever a question that they weren't going to see them. We did as a program leadership, whether we did, but I don't think the residents themselves ever balked at going into a patient's room that they suspected having COVID. And to that degree, when we came around to opening up a new ICU and knowing that a new ICU team, our residents, there were too many people that wanted to help out and pitch in than could do it. And so I think that I always am impressed with my residents and with all the residents. I think at this institution have been really great about just stepping up and taking care of our community and our people.
And also, I think we need to also, I'm sorry, Dr. Engel, recognize that not every resident's going to want to be on the front lines, and can we find unique opportunities for them to be involved? We actually started an advanced care planning clinic for COVID patients. And so we actually did advanced care planning around the COVID crisis to ask specific questions of whether you would want to be hospitalized, should you develop symptoms. And so those residents who didn't want to necessarily be in the hospital, we assigned them to advanced care planning clinics and had them call patients and the community at large to do advanced care planning. And so, that worked out really nicely for those residents that didn't want to be, on the front lines, on the med-surg floors in the ICUs. Most of our residents I found in New Orleans are, build a certain level of resiliency and want to be in the hospital. So there were very few of those who wanted to do advanced care planning clinics, but there were, a fair share that helped us through this time.
That's
Just to reiterate.
Go ahead. So I think the interesting thing is that, we started off the discussion talking about the balance of patient care and education, and it really comes back to a similar thing, right? A balance of patient care versus education and keeping people safe versus doing, you know, that service that we've all pledged to do. But if you want to comment, Dr. Ingalls, I feel like sometimes service and education, you know, they come together, and ultimately when you're doing one, you're doing the other. You're taking care of patients and you're learning. So can you comment on that balance, Dr. Ingalls, of patient care and education?
Yeah, I think ultimately the way you learn to be a doctor is by seeing patients. You learn medicine at the bedside. It's really the only way to learn it. We put a lot of importance, obviously, into didactics and coursework and stuff, which you need a base or you know, a foundation to set your medical knowledge on. But when it comes down to the end of the day, you learn by seeing patients and taking care of people. And the more you see, the more you do, the more confidence you gain, and obviously the better doctor you become. So even with this kind of things where we've taken away some of the didactics and pulled away from some of the conference schedules, we are still all learning, you know, residents, students, and faculty. We're all still learning how to be better doctors and by taking care of our patients with these problems.
Awesome. And then it looks like we have one more question that I think this is actually a beautiful one to close on. But can we all go around and talk about what we feel like makes medical training in New Orleans unique or special, even in the post-charity hospital days, which I have heard about? So I can start. That helps kind of open things up. But as I mentioned before, the opportunity to train in New Orleans is really about the patients. And it's because you have this huge ability to make an impact on a lot of people that are very, very sick and a lot of people that have very, very minimal social supports. But then you see it, you know, in this huge spectrum. It's not just these really sick patients, but it's also this whole beautiful state of Louisiana, which is, you know, it's everything, and it's everybody, and it's any patient that can be affected at any level of difficulty. So you kind of come in with this mindset of, you know, oh, I'm going to help these people that really, really need so much help. And really the people that need help are every single person that you see. And it's this huge variety set among this cultural tapestry that of course has so much to offer. But I can tell you about patients that brought me gumbo when they were on chemo themselves because they couldn't eat it. They wanted at least someone to eat their mom's gumbo. And just this attitude of loving and openness and everything that is New Orleans is, I couldn't think of a better place to train.
This is Lee Engel again. Am I on? Here. So I obviously trained at, I'm an old guy now. Gonna get rid of me. I trained at Old Charity and now at this hospital. I've seen the changes from going from Old Charity to University and the days when we rolled all the patients from University to this beautiful hospital. But the one thing that remains the same is the patients really haven't changed. We are fortunate. What I always tell our program on is the pathology is tremendous and the diseases that we see is tremendous. It's terrible that we see it, but at the same time, it is great for training programs. It's great for residents and medical students to see. You know, it's unfortunate that, you know, in this zip code, I always say our life expectancy, I believe, is 55 years of age. It's one of the lowest in the country. And from many, many factors. And if you go 2-3 miles away, you get the life expectancy of 80. But it's all that pathology and that makes it a great place to train. The other thing, too, it also leaves a whole lot of places where we can make a gigantic impact. I felt at the med team way back when that even if you did something little to help somebody, you made a big impact in someone's life. And there's just so much we can do, and there's so much we have to do to make things better. And that's one of the unique things in our population that makes it a great place to train.
I'm gonna speak on that as well. You know, I trained in New Orleans and I went away and I've worked at every major hospital in this city. When I was recruited back to New Orleans, I was at Auchner and then was recruited back over to University Medical Center. I think that we have a really unique opportunity to integrate with our community. I do think as a woman of color myself, we need to do better. We need to do better for this community so that we're not seeing as much pathology. I think COVID has really shown us that health disparities are real, and we need to actually take that hugely into stock and try to prevent some of the pathologies that we're seeing and try to really encourage more social supports to be built for our patient population. It's just not fair what we're seeing right now, and it's not fair to certain groups of people. And as a woman of color serving other men and women of color, we need to do better.
Glad somebody said it.
Yeah, I mean, who wouldn't want to train here? New Orleans is a fantastic city. Like Dr. Ingalls said, the breadth of pathology is enormous. You get a great education while just living in one of the greatest cities in this country. And look, and I think everybody kind of touched on this, but you get training here gives you that unique opportunity to make an impact. The health disparities, the degree of pathology, all that's there, and we're the ones going to be making a difference if there's one to be made. So, of course you want to have that opportunity. Of course, you want to train here.
Yeah, I don't think you're going to have any problems with recruiting, Dr. Carlisle. Just show them this video.
I mean, I think that I think we're lucky also, New Orleans being the city it is. It's really a big community. And I think that's something that we push in our program, is that we are integrated into our community. We're taking care of our community. We're taking care of those people. And so when we recruit, we recruit people that are passionate about taking care of those. We make a big push in our program, and I know other programs do, about tackling social determinants of health as part of patient care as a whole, which is a funny thing when you think about emergency medicine. Social determinants really seem like very primary care sort of thing, but we're the people that a lot of the community, the people that don't have opportunity access, where the emergency room is where they go for care. And so I think that it's a unique opportunity to touch on all different aspects of care. And like you said, it's obviously, the patients that we have are amazing population, but they're amazing pathology, but they're also our neighbors. They're our community. They're people that we live with. And so I think that's a real unique opportunity we have here in New Orleans.
Yeah, and I agree with what's been said so far. I'm coming to the end of my first year here, and I've certainly learned a lot here. With the pathology, with the patient population that we do have, and I think I'd also say the staff we have here, the attendings, the other residents that I worked with. I think we have a really good set of residents and staff that helps a lot as well. I went to med school here, so I'm very familiar with New Orleans. I loved living here for that, and I wouldn't have trained anywhere else. I really had a good time during my first year so far, and I've learned a lot, and I'm sure I'm going to learn a lot these next couple of years as well. So I'm looking forward to that.
Awesome. Well, thank you guys so much for taking the time to spend with us today and sharing your experiences. I wish you all the best.
Thanks, everyone. We do have a couple housekeeping things. Just so you know, this is recorded, and you can find it on our website at the lsuhealthfoundation.org/coronavirus. And you can also see the schedule of all of our upcoming webinars, and our next one will be Friday. And all upcoming webinars will be eligible to earn CME credit as well. And Crystal?
Yeah, thanks everyone for turning in. Thank you, Dr. Ciccarelli, Dr. Carlisle, our residents. Thanks for all that you're doing. We're so grateful to have you as part of this panel today. It was really interesting, and I learned a lot, and we're thankful for our LSU family. Everyone stay safe, and hopefully we'll see you back here on Friday with Dr. Dasa, who's going to be talking about the new normal for surgery in the COVID-19 era. So,
good afternoon, UNCT.
Thanks, everybody.
Take care.